Today I'll be talking a little bit about PCOS, trying to spell out the whole spectrum. Whenever I attend a lecture on PCOS, as I did during our recent Endocrine Society, I'm always surprised about how much we don't know, but also surprised about the things we do know, and so that's what we'll be focusing on today. My objectives today are to discuss how the diagnosis of PCOS is made, to define the different PCOS phenotypes, as well as to identify the PCOS-associated morbidities and how to evaluate for them, which is often what we're doing in the adult endocrine clinic. And then again, going back to the PCOS phenotypes to discuss treatment options based on those specific phenotypes. As we're all familiar with, the diagnosis of PCOS requires two of the following three criteria. It requires either the presence of hyperandrogenism, oligo or anovulation, or polycystic ovarian morphology on pelvic ultrasound. However, importantly, it's also extremely crucial to ensure that you've at least considered other diagnoses that can mimic PCOS. As such, any adult woman presenting with amenorrhea should have a TSH, prolactin, and particularly if there's evidence of hirsutism or hyperandrogenism, early morning 17-hydroxyprogesterone to exclude non-classic congenital adrenal hyperplasia. In select women, depending on their presentation, one should consider the following tests to rule out, number one, pregnancy, checking a serum HCG. Of course, that's something that I routinely do, but of course, obtaining a sexual history and contraceptive history is important as well, and will help you guide your decision to check the HCG. If there's a suspicion for hypothalamic amenorrhea, this is an athlete who hasn't had a period for a while, or someone with a known eating disorder, you might want to consider checking an LH, FSH, and an estradiol level, and in that scenario, all will be low. If it's a patient who has other autoimmune disorders and is presenting with menopausal symptoms, you should consider primary ovarian insufficiency and check an FSH along with an estradiol level. If the hirsutism, or acne, or other signs of hyperandrogenism have occurred pretty rapidly, then one should consider an androgen-secreting tumor. And in addition to checking a testosterone, one would also consider checking a DHEAS. And if those are significantly elevated, often greater than 3 times the upper normal limit, one should consider a pelvic ultrasound or an adrenal CT. I think that particularly in the adult clinic, it's important to have Cushing's syndrome on your differential, because often women with Cushing's disease present after many years of symptoms, and probably early on they may present with irregular cycles and maybe some abnormal hair growth, and so checking a midnight salivary cortisol or 1 milligram dexamethasone suppression test, particularly if the woman has underlying diabetes, high blood pressure, or of course any of the stigmata of Cushing's syndrome. One should also consider acromegaly if the patient, of course, has physical features suggestive of acromegaly, frontal bossing, spaced teeth, large hands, fleshy hands, or if they have a history of frequent sweating, skin tags, that sort of thing, or family history of pituitary tumors. So again, I go back to the criteria at which should be involved in diagnosing PCOS. And if we use these NIH criteria, there's a whole slew of possibilities, different phenotypes that a woman with PCOS may have. There's the classic PCOS that has hyperandrogenism, irregular periods, and polycystic ovaries on ultrasound. But there's also the other type with, you can diagnose PCOS without having the ultrasound by just having hyperandrogenism and ovulatory dysfunction. The androgen excess PCOS group also defines PCOS as having hyperandrogenism and PCO morphology and ultrasound, but normal ovulatory function. And then the Rotterdam criteria include, or you can have PCOS just with PCO morphology on ultrasound and ovulatory dysfunction without any signs of hyperandrogenism, either chemically or biochemically. And so there's a wide spectrum of PCOS out there, and likely there's differences in the etiologies for each of these types, but the exact, there's not one mutation or one defect that we know of today that explains just one phenotype. And it may be just a progression of, some say that the phenotype C might be early PCOS that will eventually go on to have ovulatory dysfunction, or even a phenotype D. When diagnosing PCOS, although pelvic ultrasound or polycystic ovary morphology and ultrasound is part of the criteria, and serum androgen levels are part of the criteria, they aren't required to make the diagnosis. Someone can be diagnosed with PCOS based on history of irregular periods and clinical hyperandrogenism. Part of that is that there's a lot of problems with the androgen assays and the pelvic ultrasounds. First of all, when deciding which androgens to test, the best assay we have at confirming PCOS is the free testosterone level. However, if it's not done by equilibrium dialysis, it's very inaccurate. And assays are not standardized. Many labs use the radioimmunoassay, and that is not accurate. And actually, at UW, we send out our samples to ARUP, and they don't even measure the free testosterone. They use a calculation to give you your free testosterone level. So they're using the total testosterone, the albumin, and the sex hormone binding globulin to calculate the free testosterone level. And there are calculators out there so that you could do that yourself. And there's a lot of issues with standardization of the assay, and there's a lot of issues with standardization of what's a normal reference range, because they differ in puberty, in adulthood, in menopause, and levels differ during the time of day. So there's a lot of issues when trying to measure androgens. In regards to the ovarian ultrasound, the official definition of a PCO morphology is having at least one ovary with 12 or more follicles measuring 2 to 9 millimeters in diameter. This was based, the definition, one of the reviews I read, but there was also another review from ACE and the androgen excess group that actually required greater than 25 follicles. So again, there's a lot of variability in not only the technique of ovarian ultrasound, but the definition. And then of course it's not often recommended that we do these in young adolescent girls because they will often have PCO morphology, which is normal in development. So just a little picture as to what is being referred to our clinics compared to what the actual prevalence of disease is according to Phenotype. The majority of the patients we may be seeing in clinic are probably 50% have classic PCOS with hyperandrogenism and ovulatory dysfunction. But of unselected PCOS populations, majority have just the clinical classic PCOS, and that might just be because they haven't had a pelvic ultrasound. Or they may have ovulatory PCOS. And I'm thinking this group may be getting the ultrasounds because of their evaluation of their hyperandrogenism. So as I mentioned, problems with the diagnosis of PCOS is that different phenotypes have different risks and comorbidity profiles. PCOS patients who have more of a hyperandrogenism phenotype are more highly associated with metabolic abnormalities, insulin resistance, cardiovascular disease, and those with irregular menses and PCO morphology on ultrasound are more highly associated with infertility. And here is also mentioning diagnosis is difficult in the adolescent population and menopause population because during those times there are normal changes in circulating androgens. It's normal to have irregular periods, and it's normal to have changes on ovarian ultrasound. So that being said, and I have adolescent PCOS experts in the audience here, the review that I focused on had mentioned that when diagnosing PCOS in adolescents, it's primarily, well, of course, after excluding other possible etiologies, it's primarily focused on the clinical and/or biochemical evidence of hyperandrogenism and the presence of persistent oligomenorrhea or amenorrhea beyond 2 years of menarche. Again, the Rotterdam ultrasound PCO criteria have not been validated in adolescents and so aren't used when diagnosing adolescents. In the setting of perimenopause, so a woman may have gone through her life and didn't present for irregular periods, but may be presenting later in life, and to understand or to know that they've had a history of PCOS is important in predicting their risk of future comorbidities. And so a presumptive diagnosis of PCOS can be based on a well-documented history, long-term history of irregular periods, and a history of hyperandrogenism during their reproductive years. It's often difficult, so this is often a presumptive diagnosis. It's difficult to confirm because, again, androgen levels decline with age, even in women with PCOS. And again, there's no age-related cutoffs for testosterone. And again, after menopause, you're not going to see PCO morphology. So it's more of a retrospective diagnosis. And the reason you want to make that diagnosis is because there's a lot of morbidities that are associated with PCOS. The common ones we deal with are the cutaneous hirsutism, acne, androgenic alopecia, infertility. Women with PCOS have higher pregnancy complications. But women with PCOS are at also higher risk of endometrial cancer. There's a higher risk of obstructive sleep apnea, non-alcoholic fatty liver disease, type 2 diabetes, and cardiovascular risk, as well as depression. This is just a figure to remind you what we do know about the pathophysiology of PCOS. And one of the primary, or one of the few things that are going on to favor androgen production is that the gonadotropin-releasing hormone pulsatility is different in PCOS women. It's more rapid, and that rapidity favors LH secretion from the pituitary. And the higher levels of LH stimulate the thecal cells to secrete more testosterone. There's also a degree of insulin resistance and higher levels of insulin that stimulate the thecal cells to produce more testosterone. And this is perpetuated, the hormones, or the increased androgen production decreases progesterone, which also enhances the pulsatility, because adding progesterone will slow down that pulsatility. And because there's increased insulin resistance that's affecting the ovary as well as the pituitary gland to increase LH secretion, there's also effects of that insulin on the skeletal muscle and leading to hyperglycemia, but also on the liver, leading to increased fatty acid secretion, but also decreased sex hormone binding globulin, which compounds the hyperandrogenism. So first we'll talk about the cutaneous problems associated with PCOS, and one common thing is hirsutism. In the general population, it's mildly common, 5 to 15%, but in PCOS patients, it's much higher at 65 to 75%. And as I mentioned before, the presence of hirsutism or signs of clinical hyperandrogenism predict the metabolic sequelae of PCOS. It may also predict failure to conceive with infertility treatment, and in patients who have severe abdominal obesity, who have lower sex hormone binding globulins, the hirsutism is often more severe. Hirsutism is difficult to quantify, however. There's the modified Ferriman-Galloway score, which you assess different areas of your patient, and you give them a score of 1 to 4. And if that adds to greater than or equal to 6 to 8, then that's defined as clinical hyperandrogenism. And so if you only need a score of greater than, let's say, 8, you could have a grade 2 on 1 or 4 of these areas, or a grade 1 on all of them, and be classified as having hirsutism. And so it's certainly some women have much higher scores and higher degrees, but it doesn't take long to get up to 6 to 8. Androgenic alopecia is another consequence of the hyperandrogenism that is less frequent and presents later in life, but it has a significant impact on psychological well-being. And again, it has a high correlation with metabolic syndrome and insulin resistance. Interestingly, it has a poor correlation with biochemical hyperandrogenism. So the degree of alopecia may not correlate with their androgen levels. There's also a score for androgenic alopecia. PCOS, of course, is also associated with infertility, and that's due to the underlying anovulation. And anovulation can be occurring even in apparent regular cycles. And so even if a woman is reporting to you that they're having regular cycles, but they have other signs of insulin resistance, hyperandrogenism, it's a good idea to screen a mid-luteal serum progesterone, which would be 7 days before their anticipated menstrual cycle. And if that progesterone level is less than 4, it suggests ovulation hasn't occurred and they're not having ovulatory cycles. That being said, women with PCOS will have spontaneous ovulation. In one study, women with PCOS assigned to either placebo or metformin had a monthly spontaneous ovulation rate of 32%. So even though women with PCOS may have difficulties getting pregnant, it's still possible, and if they do not desire pregnancy, it's important that they be counseled about contraception. But it's also important to understand other infertility factors affect women with PCOS and their partners, and doing a full evaluation, including looking into male factor or tubal factor, is necessary. If women with PCOS get pregnant, there are higher complication rates. There's a higher incidence of gestational diabetes. There's a higher rate of preterm delivery and preeclampsia. Some of these higher complications are due to confounders such as multiple pregnancies due to infertility treatments, higher rates of obesity. As mentioned earlier, women with PCOS are at higher risk for endometrial cancer. They often have high risk factors for endometrial cancer, which include obesity, hyperinsulinism or diabetes, and abnormal uterine bleeding. Currently, there's no data to support routine endometrial ultrasound or biopsy of asymptomatic women at this point, but women with a history of PCOS, I think it's important to ask them, even after they've gone through menopause, if they've had any abnormal uterine bleeding, because they've had abnormal uterine bleeding their whole life and may not recognize that having some spotting after menopause is abnormal. And so I think it's important to ask that direct question: have you had any vaginal bleeding after menopause, to ensure that they shouldn't be getting a biopsy. Again, PCOS is often associated with obesity, but it is not required for the diagnosis. And it's important to point out that the incidence of PCOS hasn't paralleled the obesity epidemic. There's been a modest increase in PCOS, but not as significant as the rise in BMI. But it's important, if obesity is present, to recognize that women with PCOS who are also obese are going to be at higher metabolic risk. And that's related to the higher levels of androgen. Obesity impacts the phenotype of PCOS because the obesity is often associated with lower sex hormone binding globulin, thus there's higher bioavailable androgen. And there is also increased testosterone, DHEA, and androstenedione production. I reviewed this already. Some other comorbidities that we don't always think about in PCOS are depression. There's a much higher prevalence of depression in women with PCOS, and that is independent of whether, when you control for obesity, androgen levels, hirsutism, acne, and infertility. The history of suicide attempts are sometimes higher in PCOS cases versus controls. And there's also higher rates of anxiety, panic disorder, and eating disorder. Women with PCOS are at much higher risk of obstructive sleep apnea, much higher than you would predict. After controlling for BMI, women with PCOS are 30 times more likely to have sleep disordered breathing and 9 times more likely to have daytime sleepiness. And it seems that when women with PCOS are treated with hormone therapy, namely estrogen, they're less likely to have just sleep or disordered breathing. So it seems to be related to that element of hyperandrogenism. And so in our clinics, when we're seeing PCOS patients, it's very important to screen them for sleep apnea symptoms and refer for sleep studies if present. As endocrinologists, we're already familiar with the association with type 2 diabetes, and the risk is increased 5 to 10-fold in the PCOS population. And when screening for type 2 diabetes, it's recommended that a 2-hour glucose tolerance test be performed because the A1C is poorly sensitive at detecting impaired glucose tolerance, and it's that impaired glucose tolerance that seems to be associated with an increased risk of cardiovascular disease in women. It's also important to do the 2-hour glucose tolerance test in women who are considering pregnancy, because if that's positive, they're at even higher risk of developing gestational diabetes. And once you've done the test, it's recommended that it be repeated every 3 to 5 years, unless, of course, they're already on insulin-sensitizing medication. Because of the increased risk of diabetes, and perhaps because of the increased risk of depression and other metabolic risks, women with PCOS are at higher cardiovascular risk. There's anatomic evidence that supports this. Studies have shown increased carotid artery intima media thickness in women with PCOS, as well as increased coronary artery calcification, and as well as epidemiologic evidence. The Nurses' Health Study showed an increased relative risk of cardiovascular disease in women who had irregular periods, and a Women's Health Study showed women with a cardiovascular event had lower sex hormone binding globulins and higher calculated free androgen index. So neither of these studies were they collecting data of whether a woman had PCOS, but these are all indirect suggestions of PCOS. There aren't many studies looking at the rate of cardiovascular events and the age of onset of cardiovascular disease in women with PCOS, and thus we're left with modifying cardiovascular risk factors, managing blood pressure, managing BMI, and preventing the progression of impaired glucose tolerance, managing lipid profiles, and of course, smoking cessation. moving on to treatment of PCOS, first line is hormonal contraceptives. This is because it kind of addresses two of the main criteria of PCOS, particularly if a woman isn't planning to get pregnant. The progestin suppresses LH and decreases ovarian androgen production. The estrogen increases sex hormone binding globulin and thus lowering androgen levels. And it also protects the uterine lining from hyperplasia. Women with PCOS may have contraindications to hormonal contraceptives, and there is no one formulation that's favored over another other than trying to avoid progestins that have less androgenic profiles. This is just a snippet from the MMWR report when thinking about considerations for using combined hormonal contraceptives in PCOS. Typically, smoking greater than any smoking at all is associated with risk, as well as high blood pressure, particularly systolics greater than 160, diastolics greater than 100, or known vascular disease. And I think that's why there's an X for duration of diabetes greater than 20 years, is because they suspect there might be underlying vascular disease. But again, always the decision comes down to having a conversation with the patient and weighing the risks and benefits. If the treatment with hormonal contraception is not effective at treating the hyperandrogenism, there are anti-androgens available. Spironolactone is the most common. There are other inhibitors of 5-alpha reductase, competitive antagonists that are used in the treatment of prostate cancer. I don't have any experience prescribing any of these medications outside of spironolactone, and I find most of my patients with PCOS, if they aren't satisfied with the oral contraceptive and spironolactone, often choose topical treatments to manage their hirsutism and acne. Another important thing to emphasize in the treatment of PCOS is lifestyle therapy, particularly in women who are overweight and obese. But it's important to recognize that it's likely not going to be sufficient in someone who's of normal weight. In terms of the treatment with metformin, it's recommended in women with PCOS, of course, who have type 2 diabetes or evidence of impaired glucose tolerance, who failed lifestyle modifications. Kind of like the diabetes prevention trial. First-line treatment, women did best with lifestyle modifications compared to metformin. But if they aren't able to succeed with lifestyle modifications, then you may want to consider metformin. And again, the diabetes prevention program also showed similar findings that patients were more successful at preventing progression to type 2 diabetes with lifestyle modification than with metformin. And so in patients who are overweight and obese with evidence of impaired glucose tolerance, referral to dietitians to discuss diet modification should be first line, and if that isn't successful, then moving on to metformin. In regards to infertility treatment, I'll just be saying a few words on that. Clomiphene is comparable to estrogen, like letrozole are recommended. I think the reproductive endocrinologists are more commonly using letrozole now. Metformin can be used as an adjuvant to prevent ovarian hyperstimulation, but the pregnancy success rates are better with Clomid or letrozole. And so by identifying the PCOS phenotype, whether it's classic or clinical classic PCOS or ovulatory PCOS, all of which have the presence of hyperandrogenism, you definitely want to consider oral contraceptive and an anti-androgen, as opposed to those women who just have ovulatory dysfunction and PCO morphology. There's no role in the anti-androgen. So I'd like to spend the rest of the talk just going through a few cases just kind of to represent some of the challenges that come and the ambiguity that comes up when we're presented with patients who present for evaluation for PCOS. So this first case is a 23-year-old female who's coming in with hirsutism and reports regular menstrual cycles. Her BMI is 23, Fairman-Galloway score is 15, so clearly has hirsutism. Urine HCG is negative, TSH, prolactin, and FSH are normal. 17-hydroxyprogesterone is normal, so no evidence of non-classic congenital adrenal hyperplasia. You also do midnight salivary cortisol, which is normal, times 2. Because of the evidence of hirsutism, total testosterone levels are measured and are elevated. So what is the next best diagnostic step for this patient? It would not be wrong. That's definitely a possibility. So one other thing.
Diagnosis, though, right? She already has 2.
But she has regular periods.
They still be anovulatory, even though they've paired regular cycles.
Right. I think it wouldn't be wrong to check an ovarian ultrasound, but even if it does show PCO morphology, if she is considering pregnancy in the future, she'd want to know if she's having ovulatory cycles. And so if hyperandrogenism is present, but menstrual cycles are reportedly regular, I think it's a good idea to assess whether they're really ovulating. 15 to 20% of women who say they're ovulating, have regular menses, are actually anovulatory. And so checking a mid-luteal progesterone, if a woman says she has regular periods, she knows when her next is due. Checking that mid-luteal progesterone 7 days before her next period is due, if it's above 5, then she is truly having ovulatory cycles, and then moving on down the path to pelvic ultrasound. So if she did have a mid-luteal progesterone, her progesterone was 9, she shouldn't have any difficulties getting pregnant, and so if she doesn't want to, that would be important as well. You move on to a pelvic ultrasound, and that does show polycystic ovaries. And so for her diagnosis is ovulatory PCOS because she has signs of hyperandrogenism and polycystic ovary morphology on pelvic ultrasound. And her primary complaint is the hyperandrogenism. And so in the treatment of this patient who isn't planning pregnancy, hormonal contraceptive plus or minus spironolactone, depending on the effect of the hormonal contraceptive. So this case continues. She returns at age 28. She stopped OCP after 2 years, which was just difficult for her to remember. She continues to complain of hirsutism, and now she's noted that her menstrual cycles are irregular, occurring every 35 to 40 days. She has had other testing for other metabolic testing, and her insulin is elevated at 34, and her normal, but her 2-hour glucose tolerance test is normal. So what would you recommend for treatment at this time? Assuming she doesn't want to get pregnant. Her OCP. Yeah, she now has progressed to classic PCOS. She has hyperandrogenism, evidence of ovulatory dysfunction, and we already know she has a history of polycystic ovaries from her past ultrasound. And so, because again, her primary complaint is hirsutism, her primary complaint now is also irregulatory periods, the preferred treatment is going back on the hormonal contraceptive and maybe trying a different one if she has side effects. But the key is, even though she has high insulin levels, Metformin isn't a first-line agent for this patient. It's not effective, number one, at treating the hyperandrogenism, which is her primary complaint. So now this patient returns and she's 39. She was diagnosed with type 2 diabetes 6 months ago. She still has problems with hirsutism that's actually worsened. She hasn't had a menstrual cycle for a year. And her BMI is 35. Her Ferriman-Gallwey score is 20. Routine labs, HCG is negative, TSH, prolactin, and FSH are normal. So, I forgot to put in the animation, sorry. So what is this patient at risk for? What should this patient be screened for coming into your clinic?
I think one of the things is endometrial cancer. She should have a endometrial ultrasound. I don't know if that's the answer.
There's multiple answers.
That's one of the things
Yeah.
that I would do.
So she hasn't had a cycle for a year. She's had that building lining. So she may not have endometrial cancer now, but this history does predispose her to a risk of endometrial cancer in the future. She has type 2 diabetes. She's at higher cardiovascular disease. She's at very high risk of obstructive sleep apnea, non-alcoholic fatty liver disease, as well as depression. So all things to be considering when evaluating these patients. So case number 2, this is a 23-year-old female who comes in complaining of irregular menses for 3 years. Her last period was 3 months ago. She reports her periods are very unpredictable, occurring every 1 to 3 months, variable flow. She denies any acne or hirsutism. She has no history to suggest estrogen deficiency, reduced energy availability, excessive psychological stress, used to suggest a functional hypothalamic amenorrhea. On exam, she's overweight, but there's no clinical hyperandrogenism. Urine HCG is negative, TSH, prolactin, and FSH are normal. What's the most appropriate next diagnostic step for this patient? Wrong answer. So even if they have no clinical hyperandrogenism, it's still, I think, a good idea to rule out biochemical hyperandrogenism. The assays, like I mentioned, aren't great, but if you do get the biochemical hyperandrogenism, then it avoids having to do the pelvic ultrasound. And knowing that they have biochemical hyperandrogenism, also that phenotype puts the patient at higher risk for metabolic disease. And so knowing that, I think, is important. You check that for her, those levels are normal. And so the next step for this patient is the pelvic ultrasound. And on her pelvic ultrasound, we do see polycystic ovary morphology, and her diagnosis is the non-hyperandrogenic PCOS. And it's important to identify this or sort this from the other types of PCOS because metabolic comorbidities are less common in this phenotype of women with PCOS. They may have a higher risk of infertility, but the metabolic screening may not need to be as repeated as frequently as with other PCOS phenotypes. Any question?
Did you do any reading on inositol? It's a supplement. Like I noticed, like Endo Society has been doing like studies with it, and I had a patient actually that I saw in clinic with PCOS, and she like brought in like her shake that has inositol in it that she heard it was like this PCOS formula, and like actually some of the studies that Endo Society published, like it did show that there is some benefit in PCOS, but the studies are small and it seems like a newer thing, so I don't think you looked into it at all.
Yeah, I focused on the reviews from 2015 and 2016, and they did mention inositol in those reviews. Maybe it's just too new to be mentioned in guidelines.
But I've seen it mentioned several places, like it's in patients are, as you say, already sort of jumping on the bandwagon.
What's it supposed to help with? What aspect?
I think more so the metabolic effects.
I've been meaning to look into it.
And I think there's like some data with like a smaller study that found some benefits.
I'd never heard of it when the patient came in, but then
Yeah,
I
and
one
then
of
I
the
started
3D
seeing
emails
emails.
from like Endocrine
Yeah.
Society a few days later mentioned inositol, like, oh, yes, she's ahead of me.
Yeah, we were in clinic together with that patient, and then I started looking into it too. So
Yeah.
this is interesting.
I didn't get a chance to look at that.
I always wonder about that last presentation, the very last presentation. I mean, any cause, I've always heard that any cause of chronic anovulation can lead to polycystic ovarian morphology, which makes me think that probably some of those people have some variant of PCOS, but I think this is a bucket that probably contains a lot of other people, which would then explain why
They don't have a higher metabolic.
yeah. So I think that might not be a terribly useful bucket because
Well, I think it helps if you fall into that bucket, you can tell the patient that you're at less risk for diabetes and cardiovascular disease.
yeah. But you might not, I mean, I'm just not sure that the PCOS label is helpful for those people.
Right. Genetically, they're probably a different group, you know, and just like genetically, there are people who have obesity who then go on to have what looks like PCOS, but probably really don't if they just lose the weight, as opposed to the ones who are always hyperandrogenomic and always insulin resistant, even as children. So probably genetics is going to really help us sort it out a lot eventually.
Eventually, yeah. And it might come down to just the genetics that encode that GnRH pulsatility, which haven't been sorted out.
How common is this ovulatory PCOS? One of the cases you mentioned was ovulatory PCOS. So I was wondering how common that was.
One study commented that it was
So hirsutism plus polycystic ovaries,
but normal.
regular periods.
Right.
So ovulatory PCOS, we don't commonly see them in our clinic, but apparently in unselected PCOS populations, they're about a third. And
It'd be interesting to see how many of those women actually are ovulatory if they've gotten that mid-luteal adjustment.
right, so these are unselected PCOS
Regular
populations.
periods, and there's an assumption that they're ovulating. And when we went back and looked at those women, we'd actually find that they are actually not ovulatory.
Which is something I didn't think about a whole lot before. You kind of take it face value if a woman says her periods are regular, then she's having regular periods. But I think it's always important to confirm whether they're really having ovulatory cycles. Because there's a good chance if they have signs of hyperandrogenism that they may not be.
It is puzzling to me what would cause regular withdrawal bleeding if a woman is not ovulating.
And I think it's just probably different perceptions of
Yeah.
what a menstrual cycle
My
is.
regular period means my regular period, the period that I've always had.
Exactly.
Like if someone's really having 28, 30-day regular periods, your slide data doesn't back me up, but I feel like that seems like a pretty strong marker that they are likely to be ovulating. Versus, yeah, I have them regularly, but it's more.
But if you consider a regular cycle, anything from 21 to 42 days, probably some of those normal people out towards 42 days.
Yeah,
They're probably not really ovulating.
Right. And it's just one objective test to assess whether they're truly ovulating and kind of put that issue to rest. But I don't think this data was based on whether they've had mid-luteal progesterone testing. I think this is just self-reported.
So my first thought was, because there's a lot of reliance on getting an ovarian ultrasound, I don't find that the ultrasounds are often telling us the info that we want. If we're trying to say that you have to have 12 or more follicles that are 2 to 9 millimeters in size, I often just have multiple follicles, or it'll say cysts in the ovary, and there's nothing classified. Sometimes I get that ultrasound report in those equivocal patients that you're not sure what they might have.
Right.
and get an ultrasound that's not all that helpful to give you a diagnosis.
I agree, and that's why in my scenarios, I often went to laboratory testing first to see if that could give you the diagnosis as opposed to the pelvic ultrasound. Not only is there technician variability, but it's also not a very comfortable test to subject a woman to, particularly a younger woman who hasn't been pregnant. So I try, although this ultrasound is in the criteria, I try to use it as a last resort when I haven't, when all the other testing has come up negative, because there's technician variability, but there's also variability in the reading of the ultrasound, and the probes have changed in their the frequency and the quality of images, and I think that's where the 25 follicles have come around, but not everyone is following that criteria, so it's very confusing.
It so rarely changes your management. Like you see this woman, like one of these women, I think, a young woman who has hirsutism and regular periods. You're talking about somebody who you're wondering if they have PCOS based on hirsutism plus ovarian morphology, or do they have idiopathic hirsutism. You're going to manage that person the same way, no matter how that ultrasound comes back. And if it wasn't uncomfortable and it was a very reliable test, I find it's rare that I'm like that this is really going to impact my management enough to put a young woman necessarily through.
Right.
Pelvic MRI may end up being more useful.
Yeah.
And the ones where you really
again, it's not going to change my management. That's
But it might be, if you do have PCO morphology, that might, if a woman who is planning to get pregnant in a year, that might be useful information to know about their.
If she gets to the point of through production, she will get a transvaginal. 470,000 of them.
Well, I think that we've seen very few of these patients, but the patients that I've seen generally come with one thing on their mind. It's either fertility or weight problems. Those are like their main issues. So I have two questions about the weight. Other than the usual spiel of diet and exercise, watch your calories, try to exercise more. Is there anything else that we can offer them, since metformin is clearly not indicated for weight issues exclusively?
Well, it's not recommended for first line. There might be a modest weight loss with metformin in women with PCOS, but it's not usually they're not going to have the effect that's desired usually when they start the metformin. That data just emphasized that there's a modest meta-analyses do show a modest weight loss in women using metformin compared to placebo, but it did not increase weight loss in women who were using diet and exercise programs. So really the first line should be diet and exercise. But if they're not able to achieve weight loss, you can try metformin, but again, the results are not going to be very impressive, just like with most of our obesity medications. And I think in these women, given that their obesity is also contributing to their hyperandrogenism, that may be an indication for one of these other obesity medications. I just don't have any experience using them in women with PCOS, and then you also have to consider the fact that they may want to be getting pregnant and not using those medications with that being contraindicated.
Now, it's a very common part of the syndrome, right? The obesity. Is there any?
I wouldn't make that call.
No.
That obesity is part of the syndrome. I think that is
It's associated.
I think that's one of, well, the
that's
prevalence
not
of
what I said.
obesity in the general population and the prevalence of obesity and PCOS are not wildly different. So I honestly think that we've done a little bit of a disservice by linking this so closely in the mind of the medical community that, number one, women with PCOS don't get diagnosed.
Mm-hmm.
Like, you couldn't possibly have PCOS if thin. And, there's not a lot, the link is not as strong as people like to
That was
make it.
my question had to do with that.
Yeah.
Right.
So my second question was, do these really have more difficulty losing weight than the average person that's also obese, because it's really in there. Well, I'm fat because of my PCOS,
Right.
and I know it's not part of the syndrome, but yes.
But I think there's been some studies looking at metabolic function in women with PCOS and found that there can be some changes in their metabolism that we can't explain. It's different. Like why their blood pressures don't drop as much at night. So there is something inherent. And I would say that it's hard to say. In our clinic, about 80 to 90% of our girls are obese. So yes, there's that association because that's what we see all the time. And there are 10% that come who do get diagnosed who aren't. So we are dealing with the obesity piece a lot in talking about, what to do to help manage and make them more metabolically healthy. Yeah, and we do see them struggling with weight management. And whether it's more than other people with obesity, I can't quite say.
Yeah, that's what I don't doubt that many women with PCOS have genuine, physical, physiological struggles with weight. I'm just not sure that is different than people without PCOS who also have
Right.
that. But I feel like these two things collide in some women, that they are people that are metabolically struggle with weight and have PCOS, and of course that makes all their PCOS symptoms manifest with the insulin resistance. But I haven't seen, I've looked recurrently, does across the spectrum of thin to obese PCOS patients, we look at all of them, is the relationship that they have with weight different from the spectrum of or is there a spectrum across PCOS patients? Because I agree with that. The issue is that people think my PCOS is making me overweight, and there's not.
Or that
The overweight
obesity is making the PCOS
flaring your PCOS symptoms.
I
So
think
I
some
spend
of
a
the-
lot of time attaching these things in clinic.
I mean, I haven't found that any of my patients who are obese find it easy to lose weight.
Right.
So I think it's just a struggle for anyone, PCOS women included.
There is
Once you gain the weight, it's difficult to lose it.
Once the diagnosis is made or a lot of the action is done, how often do you see these patients and what do you do at each visit? I feel like after a while it's sort of quiet down.
I think that depends on where you're practicing. I'm sure there are some endocrinologists that do see patients long term.
No, you do.
2 visits.
It depends if it's early on in the diagnosis, you may want to follow up, but I think it's key to have a good primary care provider that's going to keep track of all of the various comorbidities that these women are at risk for.
And is there any role for rechecking androgens down the road, right? There really be no.
I think I don't think so.
Just the diagnosis.
When I was coming up with my fellow project, I was actually asking that exact question initially before I came up with my true project. And so I just anecdotally started asking the girls at PCOS clinic. And one thing I noticed is compared to when I asked some of the people at endocrine clinic, there wasn't the same feeling of satiety. The girls at PCOS clinic were saying more often that they didn't feel full at the end of meals. They would stop eating because I have to be watching my calories. So I don't know if that's something.
Right, and maybe that has something to do with underlying hyperinsulinism.
There's some evidence the carbohydrate craving may be different and more intense.
There's still so much that we don't know about PCOS, so.
Is there any difference in the pattern of body fat distribution in obesity associated with PCOS compared to?
I'm sorry, I missed the first part of that.
Body fat distribution,
Uh,
PCOS versus.
I didn't look at any specific data looking at body fat distribution, but I could imagine since women with PCOS are at higher risk of fatty liver disease, they probably have higher abdominal obesity that correlates with that as well as with other metabolic diseases.
I'm interested in your opinion. I agree. Have to agree. It's actually true that that the glucose tolerance test is certainly more sensitive for catching things that you might not catch with an But I always kind of circle back to what am I going to, again, it's a 2-hour test. I don't even like to do the 1-hour test when I'm pregnant. 2 hours in the neck. Like it's a bigger, more intensive thing to take out of someone's day. And yes, you maybe know something about that person, like that maybe they're at this higher risk of metabolic or cardiovascular. But are you going to do anything different for that person versus, like, if they do have impaired glucose tolerance on a 2-hour test, but their A1C was right at the upper limit of normal, or if they do meet type 2 diabetes, but their A1C is in the pre-diabetes range, you still sort of, glucose-wise, you're still going to kind of treat or not to the A1C. You're usually making the metformin decision.
Well, I think that
it gives you information you wouldn't otherwise have. And I always come down to the usefulness of telling someone they had this thing versus not. But in terms of what we're going to do, I'm not always sure that,
Yeah, I guess part of our criteria for anybody who's coming in with high risk or concern for PCOS, they all get oral glucose tolerance tests as they're coming in to screen them. We find that very helpful because, one, you're giving them this diagnosis. You're also telling them, for us as the endocrinologist, your biggest risk right now is, we're talking about type 2 diabetes. They don't care about fertility right now, I mean, urgently. Yeah, and so for us, it's really helpful to know where are they on that road to diabetes at age 15. You know, if they have pre-diabetes, we got a whole different story to talk about than if they don't have pre-diabetes.
And the A1C underestimates that in adolescence. So in that population, probably the high school and college students, the OGTT gives us more information than an A1C by itself.
And I think it also provides information for your group of women who are interested in fertility, because if that's positive, they're going to be really at high risk for gestational diabetes, and you're going to want to know that I would want to know that preconception. And also, if they aren't considering pregnancy, but aren't able to tolerate an oral contraceptive, it would be helpful to know, well, your oral glucose tolerance test was very positive. You might respond really well to metformin, or you could just try it. But I think a positive oral glucose tolerance test would signify closer metabolic monitoring in the future.
I think is it endocrine society guidelines, they typically recommend like every 5 years screen.
Yep.
So
we put together a handout that we showed to families that shows it's basically a car driving down the road, and there's a stop sign at one end. The stop sign is abnormal insulin and diabetes, abnormal glucose, and then the other end is normal glucose and normal insulin. We talk about where they are on the road and about the idea of going back down the road in the other direction. So, especially for people that don't have a lot of medical knowledge, that's kind of helpful.
What days are your PCOS clinics?
Thursday afternoons.
Thursday afternoon.
Every other Thursday afternoon.
Thursday, what time?
12:30 to
5 usually.
Saturday to 5.
They let out early today because it's the end of school and people cancel.